Thank you, Larry. Thank you so much for this opportunity. I I have a lot to share. I have a lot to share, everybody. So I'm a PT, so I treat the head and neck and TMJ. That's what I'm known for this in the city of Chicago. But I incorporate the whole body, as Dr. Zagar has mentioned, and this is a way for me to share with you. You all see patients just like I do, and sometimes patients need more than dental work, and sometimes they need like a physical therapist or breathing trainer, and that's really when to know when to refer is kind of always a question for the dental colleagues that I have. So I'm hoping this will help um, clear that up. All right, so this is a three-part series. We might do four. That's just the head and neck and the airway. Breathing is a whole other area that I teach a lot to, medical doctors, to patients in general, but there's lots that I like to share and I love to teach. So this opportunity is wonderful. I teach Dr. Mariano Rocabato's work through the University of St. Augustine. That's where I earned my doctorate. And like he said, I'm craniofacial certified, so I focus in the head and neck. I also teach through the AOMT, which is the Academy of Myofunctional Therapy. I'm a paid lecturer for the advanced course in sleep and TMD. I also do dry needling. If anyone has had dry needling is an amazing technique that releases tension in muscles and trigger points. But in 2009, I was certified. 2010, I helped that be a part of the PT Practice Act. Anything that you have, if you want me to share with you, just email me. This I find very important for dentists to know where to find a PT, because there's not a lot of PTs that do head and neck TMJ. There really isn't. You will find some, but you got to look sometimes depending on your area. But this is a list of all the certified craniofacial therapists. That link will take you to a list of all through the United States that we've certified through the University of St. Augustine. Then you'll also have, there's a group through the American Academy of Orofacial Pain that has a physical therapy group that also specializes in head and neck. This is the link for that. And also the Buteyko breathing. If you want to find someone in your area that does Buteyko training and myofunctional therapy, find a therapist. So I can share that in an email very easily. This is Mariano Roccabato. Mariano is my mentor. He happens to be Chilean. That's why I speak Spanish. My mom's side of the family is Chilean. When I first met him in 2000, I had, found out that he was teaching in Chicago, and I had no idea what craniofacial meant. And if you ever met him, he's such just a sweet, kind man, not very arrogant or pompous. He's very, very loving, but so intelligent and inquisitive about the jaw and the head and neck. This atlas, by the way, has all his slides. So when he, I think it was 2012, he ended up getting cancer and was in the hospital. He's one that can't stop. There's certain people in life that can't stop. Well, he wrote 2 atlases, got all his slides together, and you can buy this if you email Fabiola, his assistant. And if you need that email, you can always get it from me. But I think it's about $100, but it's really great to have all his slides together. Some of the slides you'll see are his. So cranial cervical mandibular centric relation. This is a concept. It's all about concepts that you have to kind of understand to get a good grasp of the head and neck. So it's a 50-50% concept. So the cranial vertebral angle, the cranial vertebral region is 50% of the problem. And many of my dental colleagues that aren't aware of the neck only are treating 50% of the problem if they treat just the TMJ. So what I'm hoping to share with you is how the neck relates to the jaw and how it affects it, okay? And if everybody, if for a moment could just put themselves on mute for a moment, there's some sound in the back, just so you know. Okay, so midlines. Midlines are important to dentists. Midlines are important to physical therapists. We might not look at all the same midlines, but this midline divides the head and the occlusion in the middle, right? So you have a right TMJ and a left TMJ. This also divides the front and the back of the head, being the craniomandibular and the craniovertebral region. So this is more of the idea that you have to understand, or if you don't do that type of work, you refer to someone when you identify a problem. So this is just a few slides from his atlas that show what is the position of the airway. So the airway, as you know, airway is a big topic nowadays, and I will be showing you a CBCT with my volumetric measurements that I get patients. Understand that airway, as you move your head, changes, right? So if you flex your head forward, you kind of collapse over your airway, it will narrow that space. When you extend your head back, and many patients are actually in an extended airway position, in this position. If you think about it, patients tend to come to you like this, a lot of them, but they don't realize this opens up their airway. They might have a very compromised Mallampati score where that you can't see, you know, under their uvula, the airway in their mouth. They're in a position where the head goes back and the jaw, in this position, the jaw will come down and back a little bit, but it'll open up this airway space. The tongue ends up dropping to the floor of the mouth. What happens when you move the head? So now we're going to talk about occlusion. So try this. So sit up tall, try to sit up tall and tap your teeth. Notice where your occlusion is. Okay, now in this position, you'll see it's an anterior rotation of the head, which means that you're in a retruded position, right? Your head, it's almost like you're avoiding getting hit by a pie or a cake, but you're in this position. Now tap. You should feel that your jaw has moved forward, and in this case, it's moved forward 1.5 to 2 millimeters in that position. Now, this is an article from the Crandibular Mandibular Function Journal that shows the position of the teeth in these different postures. So you've got this forward head. So if you go from sitting tall and you kind of drop your sternum and you go into a forward head and you tap, you will feel a change in the bite. You'll feel that the lower jaw has moved back. If you go back to neutral, a good head and neck posture, you'll feel normal occlusion. When you are in that retruded position, like we just saw in that picture, that brings the lower jaw forward. Now this is just head forward. So if you drop your head, go ahead and drop your head for a moment, let your jaw relax and tap your teeth. Now when I do that, my lower jaw goes forward and I'm edge to edge. Back to neutral, and then if you drop your head back, you'll feel that the jaw has moved back and your teeth move, your occlusion is now more class 2. So this is just for you to see that there is a direct link to head posture and change of occlusion. It's very important to understand that there's whenever you move your head, your jaw it's a suspended bone that's connected by ligaments and muscles that is floating, depending on the pull it has with the connection of the head. Now the head, think about it. If you look at my chin, my side view, my hyoid bone's up here, my sternum is here. So this, you have connections of the jawbone to the sternum through the supra and the infrahyoid muscles. So that connects to the jaw. Now notice what happens from the distance of my sternum to my chin. If I drop my chest and I go forward in a forward head posture, this distance is now longer from here to here compared to here. So there's always a pull backward of the mandible when we have a forward head posture. All right. So the role of the cervical posture and the mandibular position, there's always, if there's a change in mandibular position, it can also change the posture of the cervical spine. And conversely, the posture of the cervical spine is also linked to TMJ symptoms. So forward head posture can affect the range of motion of the mandible, the path of the movement, and the associated muscle activity. Now, if you haven't seen this posture image, this to me says it all. Your heads weigh about 10 pounds. And I've treated many dentists in my career, and tell me how often your head's in this posture while you're working. It's impossible. And I will tell you, I'm not in the greatest posture, but I do certain things, exercises to help me balance my body so I don't become, affected by my work as much. It depends on how committed you are to correcting it. But this is a compression of your head weight in a neutral posture, right? You've got a cervical lordosis. You always want a cervical lordosis. Then a thoracic kyphosis. This is a normal kyphosis, and a lumbar lordosis. These are natural curves. When the head is positioned directly over the head and neck, the neck and the spine, you're gonna compress 12 pounds. Every inch you go forward, you're gonna end up loading 20 more pounds, and then even more, another 10 more pounds. But notice the curve here. You've started getting a straight neck, an inverted cervical spine. Even worse here. In this case, there's many people that end up with no injury, but cervical, lower cervical, C5, C6 degenerative changes with osteophytes, narrowing of the foramen, and they're wondering why this happened to them. It happens slowly over time. So understand that your posture will affect how healthy your neck is. And the joints, the cervical spine joints, the facet joints on either side depend on the alignment. And so my goal for all my patients is to get them in proper alignment. So these are just some articles, and if you all want any of these articles, I can share them with you as well. They're just showing how posture is linked to bruxism. The more your head is forward, the more chances you will have to tighten up your jaw and the base of your skull. There's a good image of this right here. So you'll notice this in this image on the right, she's in good alignment. She's got that cervical curve. Here, her neck is forward. She's probably on a computer too much or looking at her phone or iPad, and she's slowly causing degenerative changes at C5, C6, C6, C7, right where her head comes away from her body. That's where the most of the strain happens, because people tend to hang off of that area, and their muscles in the back of their head end up holding the weight of the head. That causes trigger points to just fill up in the posterior muscles. So not only that, you will cause, notice here, the distance between her chin and her sternum is a lot longer than here. So for her, there's going to be a pull of her mandible to open, and she's always going to have tension to close her mouth. And she won't even realize she's doing it. Lots of these patients are clenchers all day. Again, these are the natural curves we want. So think of yourself and how often you are in these curves. And know that physical therapists, chiropractors, osteopaths that use their hands, they all are trying to achieve curvatures like this. At least our practice is known for trying to restore cervical lordosis. What does this create? A healthy airway position. As long as your tongue is in the roof of your mouth is gently closed, not open, but gently closed, teeth lightly together or slightly apart, lips relaxed but together. And you can gently breathe through your nose. That's a healthy patient if you can be in that alignment. Now, these are different postures we see every day, right? So we have the sway back posture, and you can figure out where you are. The sway back posture is this one. The lumbar excessive lordosis, those are like a lot of my hypermobile women tend to have a really arched back. A thoracic kyphosis is when you're hunched up here. That forward head posture, I think a lot of us have that. And then that good alignment is that plumb line going right through the ear, middle of the shoulder, middle of the hips to the ankle. That's a perfect plumb line. Now, one of the reasons I got into breathing was because this was my daughter at age 4. And this was a very, very similar image of her. She's a swimmer and she's now 11. She's much, much better in terms of alignment and breathing. I had no idea that she was a mouth breather all her little 4 years of life, but this is typical of what's happening these days with children. Just understand that children need movement. We all do. We're not supposed to sit there all day in front of computers. We really aren't. And the more we are inactive, the more we lose the ability to maintain these postural, the postural alignment that we need. So that's a straight neck, that's a dropped sternum, a winging shoulder blade, a distended belly, and notice the jaw is set back. Her jaw is also retrognathic. So we've done some expansion, we've done some myofunctional therapy, some breathing training, and she's much better. So TMJ dysfunction is significantly related to forward head posture, especially in adolescents. Those adolescents seeking orthodontic treatment, if you correct that forward head posture, their symptoms go down. This is also a PT, a colleague of mine that's known for TMJ. He's in Atlanta. He wrote a really good journal article on how the cervical spine affects the TMJ, and I would love to share that with you if you're interested. But it goes through all the different things that we were discussing today. Okay, so we're going to talk a little bit about the neck. Okay, so how is the neck affecting the jaw? So you've got the alar ligament, right? So this is the craniovertebral centric relation concept. What is centric? We just want alignment. We want everything to be in line. The alar ligament, if you know what the alar ligament is, it's this ligament that connects the odontoid process. This is kind of the base of the skull, the first vertebra, and then the odontoid process. And I'll show you a better picture. That's C2. This is the odontoid process. It's a bony prominence that when connected to the atlas, it sits right there. It creates 50% of the movement. These two bones together create 50% of cervical rotation. So it's really important to understand that if you're locked up in the upper cervical spine, you're going to have a very big reduction in range of motion. So this is the midline we're aiming for patients. This is an open mouth x-ray. You'll notice that this is the odontoid process, C2, right there. This is the lateral masses of atlas, which is a C1, the first vertebra. This is with the patient's mouth open. And notice right below this is a upside down triangle, which is C2 spinous process. So the spinous process of C2 is the first spinous process in the neck. C1, there's no spinous process. There's just an arch there. So one way to find out if there's a rotation of C2 is to see it, is it in midline? This one's perfectly in midline. If it were rotated, you'll see it off to the side. You'll see that in a minute. Now, notice these two areas are even. That's a centric relation for the upper cervical spine. So this is a patient, an x-ray, lateral ceph x-ray, that you'll notice if you look at the base of the skull between, this is considered CO and C1. Notice that distance versus this distance. This is a lot more narrowed. And when you see this, there's normally not enough space between the skull, the first vertebra, and the second vertebra to have what we call functional space to keep that lordotic curve. So this will create another little line in that atlas, which when you see a double arch of atlas like this, it means that there's a rotation. Now, we're talking about the atlas. So let me stop share real quick. The atlas, so this is a cervical spine, upper cervical spine model that's connected by this little string. This is the base of occiput. You see the foramen magnum, this hole here for the spinal cord. Then you see the cervical spine, it just fits nicely there. And if you see the side view, you need enough space between this bone and this bone to have enough space for the greater occipital nerve, the suboccipital nerve. There's a lot of nerves that come out of here. So you don't want a forward head that starts to compress that area. So what happens when this space is not, there's not enough space between each vertebra, it'll cause a twist of the first vertebra. There's nowhere else for it to go, so it'll twist. Now, I always use an airplane analogy. So you'll see that as an airplane rotates, it always rotates. One side goes down, the other side goes up and forward. Okay, so if you can think your atlas is, and if you want to feel your atlas, you feel it, right? Go right below the earlobes, right behind the angle of the mandible, the back of the mandible there, just push in, and it's normally pretty painful. But on certain people, you'll feel one side sticking out. And in many of my dental colleagues, their right side is sticking out and further and forward because they look left a lot if they sit to the right of the patient. So that position, always putting your head in a left rotated position, will cause this bone to slowly change, especially if you have a forward head, because it closes that space. Let me go back to that. So the airplane image, this would be considered a right rotation of atlas. So consider that the skull sits right on top of it, and now this atlas has no space, so it's twisting. So the right side goes down and back, the left side goes up and forward. That's how airplanes turn. I want you to consider that that's the similar way that that bone shifts between the skull and the second vertebra. What ends up happening is that it will change the position of the mandible. So notice here, it's a right rotation of atlas. So when I look at open mouth x-rays, and now we do a lot with cone beams, so this is, the cone beam's a forward picture. This is one looking right at me. The patient's face is the right side of his face is here on that side, and the left side is here. So whenever I see a bigger space to the right of the dens, the odontoid process, I know he's rotated left. What does that cause? It causes a drop in that left side occlusal plane. So this will start to angle down. And what I end up doing is I put 2 fingers right at the molar, premolar region, and I normally will feel a hard hit on this side, a first hit on this side. Now, here's another image. Here, whenever you see in your cone beams, if you get cone beams by Dr. Zagar, you will see this double arch. You're not supposed to see 2 arches in a lateral ceph image. You just shouldn't. It should be a pure side view of this bone, right? You should not see 2 of these, 2 of the first vertebra. That means there's a twist in it. Now, with that twist, it causes, if you had an open mouth x-ray, you see that there's a bigger space on one side. So in this case, that atlas is rotated left. And not only that, the midline of the axis, which you'll see this upside down little triangle, that's the spinous process. It's shifted over to the left. So I'm going to go now. This is an image of a cone beam. Let me share with you one of the patients that we had a cone beam done. I blocked out her information here, but she was a patient, that 74-year-old patient that couldn't stop clenching, and I was concerned that she had an airway issue. She had a degenerative change in her right TMJ. This is just the report. Now, if you see this, let me see if I can, you can see that the right TMJ has a lot of problems, a lot less space between the articular eminence and the bone, and look how the shape of the bone has changed. So she's got some degenerative changes there. And that's the left. Now, what do you think of this? If you saw that, this is a cervical spine patient. You see that double arch of atlas. And what kind of space does she have at the base of her skull? She's in a tight forward head, and she's clenching all the time. Not only that, she's hitting harder on that right side. So it causes, over time, you hit harder on one side, it causes a lot of compression on that side, and it will degenerate the bones. Here you will see that there's more space on this side. So there's a twist there. But I was very happy to see that she did not have an airway problem. That her airway was open enough, you know, anything over 100 millimeters squared is considered normal. So that I just wanted to share with you. Thanks to Dr. Zagar, any patient that I'm concerned with their joint health and their TMJ, their neck, I like to see their nose because I want to know how well they're breathing through it. If they've got a bent septum, you know, that's, to me, all of these things I refer to. There's a team of people that I have to take care of patients because I know I can only give them certain things, and I need my colleagues to really help with making sure that this patient is taken care of. And I make sure that they're very healthy from head to toe. All right, so I'm going to go back to this. That's the picture of that image. So what do you do when there's a twisted upper cervical spine? What do you do? What we're trained in is the treatment, right? The treatment of it. And so just understand that this is an image of a patient that's going through craniovertebral treatment to balance out the occlusal plane. And if you see here, this is the image before treatment, and this is the X-ray after treatment. So notice that rotated atlas, that double arch of atlas, is not there anymore. And I'll explain how we do it. So, of course, we don't want to treat a neck that's like this without trying to get them here. Okay, so I'm doing a lot of distraction of the neck. And there's a video that I'm going to show you in a little bit of me treating a patient that you can see what we do. But so these are all the muscles in the base of the skull. These muscles get into a state of immobilization, as Mariano says. They are, those joints, you don't see a ton of upper cervical degenerative changes. You just don't. These muscles get super tight, but they don't really degenerate those joints. This muscle, the inferior oblique, notice that this muscle connects two very important vertebrae. The first one, atlas, and C2, spinous process. Remember that upside down triangle. That's what we want to affect, the connection of the transverse process of atlas, which is right here on the right. That's what you can feel if you touch here. If you touch your atlas transverse process, that's what you're feeling. And this is, notice how close the cervical spine is to the mandible. So here is your atlas, your first vertebra, and notice how close that is to your jaw. So it is going to affect the position of the mandible. So we use this muscle. If you activate this muscle, what does it do? It will pull that atlas to the right. Now, notice the connection of these muscles, just so that you understand how these muscles are connected to the head and neck. This is that inferior oblique, that transverse process of atlas connected to the second spinous process. So if that connects and contracts, it gets tighter, it'll twist, it'll de-rotate this if we want it to go to the right. If you want to go to the left, you've got to use the other side. Now, there's one more muscle we use. That is the rectus capitis anterior minor. Guess what? This was in the front of the neck. So if you think this is base of occiput, okay, so here's your base of occiput here, and the first vertebra is right under it. This is the first vertebra. This is the atlas. This is right at the base of occiput, connected to the front of the atlas. When you activate this, you're going to rotate that bone. So what we're trying to do is use what we call muscle energy to help de-rotate these bones so that we get centric relation. This is a technique that we teach patients to use after they've gone through some PT. They can't, this is not something I teach right away because they have no idea. And when you start doing it yourself for the first time, you're like, where's my right? Where's my left? This is confusing. But you'll notice here she has her head flexed and she rotates right and left. And she's going to be put in a position where these two muscles are worked to balance her atlas. So if you want to try it, this is a way to de-rotate the atlas to the left. So you'll notice that his right hand is kind of gripping his neck. And what do I do? This is what I consider a finger wall. I have patients kind of side bend to that finger wall, so it's only upper cervical movement. And if I want the atlas to go left, I have them rotate the head just a little bit. And then I put my hand right at my eyebrow area and I rotate left. And I look with my eyes and I rotate left for 6 seconds. Now, the other muscle, that's using the inferior oblique on the left posterior aspect of my neck. Then I'll go here, look right, rotate right, and that will activate the front little muscle, the rectus capitis anterior minor. So just understand that what we're trying to achieve is alignment. So we have that balanced occlusal plane. So orthostatic position versus loss of orthostatic posture. When we lose this alignment, we lose spinal mobility and we are subjected to increased intra-joint compression. So we want our curves so we aren't compressing certain areas of our spine. The connective tissue also will be under tension and there will also be some muscle activity. So I haven't met one one dentist that has a relaxed neck. So the more your head's forward, and that you don't, if you don't do the work to try to straighten up every day between, you know, work, you'll end up having a inverted cervical spine. And just know that over time it causes wear and tear. It causes shear forces. Anytime you have shear, bones start to grow, and there's osteophytes that happen without any injury. So we're going to talk about the craniovertebral angle concept and cervical lordosis. So the development and maintenance of cervical lordosis is critical. As you lose cervical lordosis, this causes degenerative changes in the neck. We treat kids in our practice, and I wish I saw more kids. Probably 40% are kids. And kids become adults that are, you know, out of alignment from age 5. And they have healthier joints because they don't have, you know, they don't have the years of it, but they're headed in the wrong direction. This is a picture of 2 cervical spines. Now, if you can see, it's pretty easy to see which one is in lordosis, right? Now, when I see this, I'm happy to see there's what we consider good functional space between these 2 bones. You've got the base of occiput. That space is nice and big, and so is this one. And you've got this curve. Look at this one. Okay, so this child has an inverted cervical spine. The base of occiput is very narrow between CO, C1, C1, C2. Not only that, when you start seeing this vertical growth pattern, you notice that the mandible here, if I made a line connecting the mandibular plane, where would it continue? Would it intercept the skull? Yes, it would. When I see this, it means it's a cervical spine patient for life. It's not good. So the earlier you get them in, you're going to be able to change the little children that have this. Kids have this posture. Notice what happens here. If I put a line at the mandibular plane, it goes under the occiput. That's what you want. You want a jaw that grows down and forward, not down and back in that clockwise pattern of growth. So you can measure this. This craniovertebral angle is easily measured. It's formed by the McGregor line and the odontoid plane. So here's the McGregor line, base of occiput to the posterior nasal spine. Odontoid plane is right here, which is C2. That's the odontoid process. It intercepts right in the midline here. You want that angle to be about 101, plus or minus 6. And if you made a line between the back of each vertebra, all the way from C1 to C7, you should have all the bodies in front of it. So this is a nice lordosis. Here's another image of it. So here you have the mandibular symphysis. You have the hyoid bone hanging. It's basically always right in front of, hopefully in front of C3. And you have this curve. But you want this 101 degree. Notice this is not the case for patients that have forward heads. So if you go into flexion, as your head goes forward, it should open up this space. That's normal. If you extend your neck, it narrows that space. We're going to be talking a little bit about the tongue next time, but I just wanted to show you how intricate the tongue is and how many connections and muscles there are to this little tiny bone called the hyoid bone. Okay, so I'm going to stop share here and show you a couple of videos. And some of the videos, unfortunately, some of the videos are, actually, you know what, I'm going to do this. Okay, Larry, can you see a green screen right now?
Yes.
Okay. All right. So I'm going to have to, for some reason, the audio is not great. So part of this, I will stop for a moment and explain if you can't hear it well. So this is a head and neck standing evaluation. This is what I do every day in the clinic when I evaluate the head and neck.
There's no audio.
So basically, you're going to look at the head and neck and the posture. You want to look at their alignment. See if one shoulder is higher than the other. You want to check the feet too. Do they have really flat feet? Are their knees bow-legged? Are their knees knock-kneed? You want to look at their face. Make sure that they don't have facial asymmetry. And if they do, note if the eye is lower, if the ear is lower, if the side of the mouth is lower. Here, we're just checking range of motion. You want to see if there's an obvious limitation. Now, this patient's hypermobile. You can notice she's got a lot of flexibility. So she's just going through flexion, extension, right rotation, left rotation, side bending. Now she's going into a flexed cervical spine. We're going to rotate her head to the right, have her mark how far her chin went. So we compare right and left to see if there's an even upper cervical rotation. Remember that the atlas and axis, those two joints make up 50% of rotation of the cervical spine. So now we're going to look at her side view. I always do a plumb line. I want to make sure that the meatus of the ear, the shoulder, the hip, and the ankle are in line. So you want to notice how far forward the shoulders are. How far forward is the head? The joints of the neck and the shoulder all compensate. So the position of the ear and the middle of the shoulder should be in that alignment. The side view, well, you can also see if there's too much arching in the lower back. A lot of my TMJ patients are hypermobile and they tend to have this excess lordosis. Here I'm just trying to align her a little bit better. So here I always try to have them feel what good alignment is. Does it feel natural? No, there's going to be a lot of tension of muscles trying to get the patient out of that posture because muscles are relentless. They are tight and holding people in this improper posture.
Jennifer, Dr. Isabella had something, your audio switch is turned off. Can you say that again, Isabella?
Sure. When you look at the video, the icon that next to play is the audio, and that's not like there's no stripes next to it, so that tells me that it's off. So if you move
right
it
here?
forward, yeah, then you'll be able to tell. That.
Yay, thank you.
You're
awesome.
welcome.
So in this posture, she's going to have much more relaxed shoulder and facial muscles, and also cervical spine muscles. In this position, she has a good malar bone, which is basically her cheekbone, over her sternum. You want to have your cheekbone always over your sternum. That creates the proper head and neck angle. We call this the cranial vertebral angle. In this position, I can also check the level of the hips. I'm going to go down on one knee. I would like to make sure her iliac crests are even. So I'm on top of the iliac crest. In that position, I'm noticing right now that she has a left lower iliac crest. I'm going to raise this up just a bit. Okay. And her SI joints are 2 points right where the sacrum and the ilium meet. I'm going to ask her to do a forward bending test. Go ahead and bend forward. In this position, her left SI joint is moving first and further. I'm going to have you come back up. Turn this way so everybody can see. So here I'm going at the level of the iliac crest. You'll notice that the right one is higher than the left. I'm here at the level of the SI joint. Step back just a bit so you can bend forward. And that left SI joint moves first and further. Come back up.
You can't see it that well, but
leg, bring your right knee up and hug that right knee. You want to see that SI joint drop. Come back down and switch legs. And notice that one does not drop. So she has an issue at the level of the left SI joint with hypomobility. One of the things that we see with issues with the TMJ is that there's a correlated opposite side SI joint problem. So as I continue up to the level of her TMJ, I'm going to evaluate for altered mechanics there.
okay, so just understand that this is kind of a sequence that we always do. When we are, I'm going to stop share for a moment. When we evaluate every patient, I want an even level ground for them to walk on. I don't want one hip to be higher than the other. So your spine adapts to all of that, and you're unaware of it, but we need an even playing ground when it comes to walking. Now, if I go to, let me go back to here. One moment. Okay, so
This is a brief demonstration on evaluation of the head and neck in sitting position. I'm going to have you open and close your mouth several times. And I'm going to feel either side of your mandibular condyle. Go ahead and open and close. And what I'm feeling for is for the condyles moving out towards my hand. Both condyles are excessively translating on this patient. She is considered a hypermobile patient, so I'm expecting that, but you want to note it. Do you feel any joint noise? Go ahead and open and close. Go right and left, right and left. I'm feeling for any crepitus or clicking. Go forward and backward, forward and backward. And there's a little click on the left side. Open and close again. This patient is considered a hypermobile patient with excessive translation of the condyles. Now, I'm going to use my flashlight. I want to look in her mouth. So I'm looking at her airway. I'm looking at her palate. I want to see how wide her palate is and how high it is. She has a moderately high palate, and it's considered moderately narrow. Now I'm looking at her airway. I can see under her uvula. I can see her tonsils. I'm going to ask her to keep her mouth open, lift up your tongue behind the front teeth. As she lifts, she's not really needing to close her mouth much, so I know her elevation is pretty normal. I'm going to ask you to do a suction of the tongue up to the palate. So I want to look at how tight that frenulum is. There's a frenulum on everybody. It's a lingual frenulum. It restricts the elevation of the tongue. So in her case, she's considered pretty normal. And you can go ahead and click. Okay. I'm going to feel either side of her neck to feel for the transverse process of atlas, which is the first vertebra. And I'm going to see if it's even. In her case, the more prominent side is the side that it's rotated to. So in her case, it's more prominent on the left side. So she's right rotated in that atlas. But there's a better way to confirm that in supine position. In this situation, I would take a pair of gloves. I'm going to check how even her occlusion is. I'm going to have her open her mouth. My fingers are going to go to the molar, premolar region. Gently bite. Now firmly bite. Hold that. Now I'm going to have her keep holding my fingers between her teeth. And I'm going to see if I can get out of either hold. And she is letting me come out of the left side. Open.
Okay. All right, so let me just stop share for a moment. So one of the things, and it's not, obviously, it's not like how precise dentists can be, and I'm not pretending to be a dentist at all, but I want to know if I put two fingers between their molar, premolar region, are they hitting even or are they hitting hard on one side? And honestly, the majority of my patients that come in with one-sided problems, a lot of them have either lost that height of the TMJ because their disc has slipped out and they're no longer as high as the other side because their disc is out of place, or they've got a twist in that neck causing a inclined occlusal plane, causing it to hit harder on one side. And that both of them we treat. We're always trying to even out the upper cervical spine so that we have a even occlusal plane, that there's no incline to it. And I'm going to share one more time. Let's go to this. Okay, so
Flex your head. You're going to rotate your head to the right. Bring your index finger to the right.
So this I find very important. Larry, can you see the green screen again?
Yes.
Okay. I do this evaluation and you can do it easily in your practice. All it is the head goes forward and then you rotate the head after it goes all the way forward, just like this. And you mark it.
Your index finger marks where the chin ends. Rotate. Find your chin on that side and mark it and look up at me. So you are looking at the distance between the right and left range of motion of her upper cervical spine between the level of C1 and C2. And in her case, it's even. There's many cases that there's a limitation in range of motion and a problem with the occlusal contact. There's times that the occlusal contacts change with the rotation of atlas. This is confirmed in also supine position.
Okay, so there's just one more. This is a technique that I teach dentists how to test the back of the neck, because a lot of dentists don't really know how to palpate there, but this is called the suboccipital triangle. And it's a way for you to have a patient in sitting posture and you're palpating the base of the occiput to the first vertebra, the transverse process that we've been palpating ourselves on, and then you make another little line to, if everybody can, that's just for the sake of knowing where your landmarks are, go right behind the earlobe. and go into the skull. That's your transverse process of atlas, right? So, and then if you go back to the back of your neck, find the base of your skull. So you should feel, you know, the base of the skull, and then if you keep going down, there's one first spinous process. You should feel kind of a
We
big
lost
old
your
bone.
audio.
Oh no. Can you hear me now?
Yes.
Okay. So if you feel the back of your head, go from the base of occiput down until you feel the first bone. Now wrap your fingers around that bone. So here you're gonna go down, you're gonna feel the bone, and then wrap your fingers around that bone. So if you wrap your fingers around that bone, that's C2. That's the spinous process of C2. That's that upside down triangle. And if you side bend back and forth, you should feel, as you side bend left, the spinous process of C2 goes to the right. It pushes into my right hand. If I side bend right, it pushes into the left hand. And that's because of the alar ligaments that keep our first two vertebrae stable. We need them, right? If we hit really hard in a swimming pool, those ligaments help, but there's a limit, right? So we don't want to put too much pressure there. But those are the areas that you palpate. Now, this is what you do.
This is a technique for all my dental colleagues to help screen out patients that may have cervical problems along with their TMJ dysfunction. You have your patient sit as erect as possible. Place your hand on the patient's head. Use your thumb at the level of their occipital protuberance. You're going to walk your thumb with a little bit of a side bending compression into the thumb. Ask the patient to raise their hand if it hurts. For the movement, I'm just moving her head into a side bending fashion, so it's compressing my thumb. You're going to go from the occipital protuberance all the way to transverse process of atlas, which is right behind her ear here. And then from that same position, raise your hand if it hurts, all the way to the level of C2 spinous process. So if they raise their hand, you know, depending on what line of palpation you did, if it was tender between CO and C1 or tender between C1 and C2, you think that there's dysfunction there. Many patients with TMJ have postural problems, and it all stems with the position of their cervical spine. If you address their cervical spine, all the dental work that you do will be successful. You will have a much happier patient because they're feeling overall much healthier.
Okay, so I'm going to stop now. And let me go back to this. Okay, so that was just some evaluation. Can you, hey, Larry, can you see the blue screen now with the skull?
Yeah, I see the center of the maxilla and the mandible. Is that
Yeah,
what you're
okay, yep, yep. So this is back to the midline. This is back to that twist of the neck causing a shift of that occlusal plane. This is just, we don't have to go too much into it, but just understand that when the jaw, when the upper cervical spine does not have enough space between the base of skull and the first, second, and third vertebra, there's a twist that happens in the first vertebra. There's only one way for it to go, it twists. What happens, it will cause, that twist will cause one side of the mandible to be higher than the other. And that's fixable if you can identify it. A lot of people do full mouth reconstruction without checking for this. This is something that's really important. You don't want to lock your patients into their cervical spine that's out of alignment. They always have tension there and maybe headaches. So again, this is a right rotation of atlas causing a right occlusal plane issue. And you'll notice that the axis is also off to the center here, off center, and it's causing that that C2 to also be rotated. So what is all of this? This is a lot about the neck. You have to understand the base of the skull needs some functional space to have a normal curvature. We always want to see about 6.5 plus or minus 2.5 millimeters of space between the base of the skull, the first vertebra, and the second vertebra. When you have a decreased space, you'll have a backward bending of the cranium on the first vertebra. So if you were to feel the back of your head, go back to the base of your occiput and that spinous process, you should feel 2 finger breaths between the base of the skull and that vertebra, that second vertebra, which is the first one that you feel. And when I do this on patients, I'll have them do it in supine. I can only normally get one or part of one. So I need to get them to help me do a bunch of different exercises to stretch the base of their skull so that we start creating that functional space of the base of their skull so that they have a normal lordotic curve. So, hang on a second. So the lowering of the mandible, what effect of occlusal changes have on the subcranial angle? The lowering of the mandible tends to cause a cranial backward bending. Okay, so a lot of my mouth breathers, they have kind of a low mandibular position. Their mouth is parted. Their jaw is not in a closed mouth position. That will cause a backward bending of their cranium. So this was a really old article that Mariano it made a big impression on him, because interocclusal appliances in a bunch of patients that were in the study, they put an interocclusal appliance in the mouths of a bunch of these patients, and what it caused was a posterior rotation of 90% of them. So that's fine in certain patients that have that space, but if they're compromised, and that means that if you have a patient that you put an appliance in and they're complaining that it hurts, it's not right, something's wrong, chances are their neck functional space is not enough for them to handle that little bit of rotation that's caused by putting something between their mouth. So whenever you are trying, and I always urge my dental colleagues to have the patient do a bunch of PT for about a month and then fit them for an appliance. Get their atlases balanced so that they don't have to keep adjusting it, right? You want a balanced atlas so their occlusal plane is even. As the patient has an appliance in their mouth and I'm working on them, I always have to send them back and get it adjusted because their neck is changing. So it's ideal to start with, nothing in the mouth, have the therapy change the posture of the mandible and the curvature of the neck, balance out the upper cervical spine, and then create the appliance. That's a lot more successful in many cases. So PTs are great. PTs, my practice, we have an office in Lakeview, an office in the Loop, and I have 5 therapists that are very good at balancing the head and neck and the posture. One thing that really has made a big, impression on my practice is how many hypermobile patients come in. Now, if you don't know what hypermobile means, it means just loose jointed, double jointed. But you want to notice these patients because these patients are in your practice and they cause you problems. These patients are the patients that their discs slip out. And these are the tests that we have every patient have this test. And this, I highly recommend that you at least do this one, right? So the thumb, and I'll show you in a second, you can just see that this patient's finger is going to 90. Her thumb is touching her forearm. Her elbows, there's a little bit of a hyperextension here. her knees lock out. You see how her knees are hyperextended, and she can touch the floor with her hands. So notice, I can't do it, but I am hypermobile. I'm a 7 out of those 9 points. If you flex the wrist, and if you're doing a long procedure on patients, just understand their anatomy. This is not like you can change it, but you should know whether or not this, you know, if you can flex the wrist and then the thumb can touch the forearm, be careful with that patient. Give them breaks. Let them, you know, close their mouth in between. An extended, you know, 45-minute cleaning is going to cause a problem with those patients, or a procedure that takes longer. So just beware of those patients. Now, hang on. So we scale them as, you know, each point, there's a point on either side for the majority of them, and the floor on the hand, the hands on the floor is 1 point. So anything that's 5 to 9 is considered severe hypermobility. 3 to 4 is considered moderate. So the majority of my patients are women. There are some men that have hypermobility issues, but not as much. But those women tend to have discs that slip out, TMJ discs. All right, so that's this. All right, so now what I'd like to do is stop share. I have one more video to show you, and then we can open the floor for questions. I'm gonna, hold on one second. Okay, so let's see. I might need whoever was so nice to tell me about the volume. This is a YouTube video, so that might be an issue. Here I go. So I'm going to share screen. And I'm going to go here. Larry, can you see me with a patient in front?
Yes.
Okay, so let's just see if the volume, whoever said that about the volume, I'm so excited, but tell me if you can hear it here. And I'm assuming it's this thing. Let's try.
You're very low. Can't hear you.
So for that, check your computer audio and make sure you're all the way up.
Yeah, this is it. Okay, and I will kind of throw in what I'm explaining, the main points. Here, I have her supine. I put my gloves on. I just want to check her occlusal plane. I want to see, is she even in supine?
Lindsay, I'm going to ask her to open, and I'm going to molar premolar region on the other side. As she bites, I'm going to look harder. She's sitting good on this left side. But this right side comes out. She's hitting a little harder on that left side. Open. Swallow. And do it one more time. Open. Gently bite. Firmly bite. And I can come out on this.
So this is, you know, I'm going to show you, it's about a 7-minute video that explains how I balance that, right? How do I get her to hit even? Right now she's hitting hard on one side. That's all we know. This is a video that I filmed last year at the University of St. Augustine. They wanted to have a little clip of how I balance the upper cervical spine and the mandible.
Concept that we want to make sure that the atlas and the axis are in good positions and moving with it. So what I ask Lindsay to do is completely relax. I'm going to bring her forward, test her atlas axis rotation. Now find your pin on that side of your index finger, mark it, and find your pin. You'll notice she's moving a lot more to the left.
So this was the same type of test that we did with that one patient that brought her head forward and sitting and rotated, right? So try that for a moment. It's not hard to do. And I think if you could get in the habit of doing this, you'd be able to identify neck patients. If you went forward, right? And then I gently kind of hold their head, but I'm just guiding them into rotation, and I get to the end. I mark that. I have them put their index finger at their chin and mark it. Then I rotate the other way. And I try to get the end range and mark that. And oh, you can't see that. I'll do it again. So you want to see, is it like one can go here and one can go here? You want them to be pretty even. And it's just information. It doesn't mean anything other than there's more rotation on one side more than the other. Let's go back.
Don't hear anything.
You can't hear anything, Larry?
No.
Does anybody else not hear anything? Because I'm not doing anything
I
different.
can hear it.
You can. I'll explain. I know the audio is not as good as the other videos, but I'll explain it. So here, I'm just saying, okay, where did I palpate? We found that there was one side that moved further than the other. Then I put my fingers right at the atlas. I'm feeling whether or not the atlas is more prominent on one side. Does one side stick out when I put my fingers there? Now I'm explaining the wings of the airplane, how that affects. Right now, I'm explaining that my hands, my arms out to the sides as I rotate. And just know that if I said that there was more prominence here, that this bone is sticking out further on the transverse process here than here, we know that there's a twist happening that makes it more prominent. What happens with the arms? This happens, but you always want to look at the back of the head. So this. So if it's right rotated, it does that. And that left side will come up and cause, the left side will come up and cause an incline occlusal plane on that side. All right, I'm going to go back. On my atlas, if I'm right rotated, it's going to hit harder and first on the left side, which is what she's doing. I'm going to correct it. So first, we know that right side a little bit restricted, so I'm going to work on mobilizing to PT3. Okay, so here I start, and I don't expect you all to understand any of this, but know that PTs do a lot of joint mobilizations to mobilize areas that are stiff. Okay, so that's, I'm looking at the level of C2, which C2, remember, is this bone. That's the first spinous process. And I'm putting my finger here and my other finger here, and I'm mobilizing the bone to see if they're even right and left. That's all that is. So when I find something stiff, I will work on that joint. We do a lot of distraction to create space.
What do you do if you have cervical spine pain when you're doing that?
You go gentle. You go gentle. And we have all kinds that come through. So some people you can't even touch them the first day, but we get them eventually desensitized. There's a lot of different patients, but normally, Larry, normally patients love this part. Like, and you'll notice that I'll do a bunch of work and haven't touched their jaw. And when I train with Mariano every January. I've been doing it since 2004 in Santiago. I was so amazed at 70% of the work that he did is all neck and spine. The last little bit would be, okay, we're gonna, distract the joint. It hangs. The jaw will follow the neck. So as long as you have even a good cranial vertebral, angle, lordosis, even atlas, good functional space, the mandible will hang in the right position. Okay, so I'm gonna go back. We're almost done. So I'm just working it. Just working back and forth, trying to stretch areas that are tight. So what does that do? It stretches the base of the skull. It opens up that space that gets so tight on people. Here I'm putting pressure right at her frontal bone going down. That'll help stretch COC1. Sometimes the atlas gets stuck on the occiput. Just know that a lot of patients with immobile, we call it state of immobilization, the upper cervical joints, that atlas sometimes gets stuck, and it just gets stuck against the occiput. So you want to mobilize that and get that moving. So just so you know, we can't just go into that muscle energy technique. You have to open up the space or it won't work. You need to create that functional space between occiput C1 and C2. And now we're going to use that muscle energy technique that we were talking about. So they use their eyes and their neck muscles. So here she's using her anterior rectus capsus anterior minor. Now she's using her left inferior oblique. It's either you're using right now she's using her right anterior rectus capsus anterior minor, and now the left.
Jennifer, you have a few minutes for questions coming up.
Yep. I think we're done basically after this.
A lot of dentists use these myofunctional devices, TENS units or whatever, or this JVA to measure. How do the therapists look at those instruments?
You know what? I actually was connected to one recently, and it I mean, you got to be on it for a long time to relax the jaw, but your teeth definitely, after being on, I think I was on it for 45 minutes at that. That was a few weeks ago. I was interested, and I have a dental colleague that wanted to share some interesting information with my staff, and my teeth definitely didn't meet the same. So I think it relaxes the jaw. I don't know how functional it is to, you know, I don't know how much the patient is able to get to that point of relaxation on their own. We teach a lot of exercises that I was going to go through next time around how to relax the mandible, but it's a lot around tongue posture and opening and closing the jaw with the proper alignment with the tongue position. So I think it's great. I don't have a problem with it. I think when you're making appliances, you want a complete relaxed face. So this just shows that after I worked on her, let's see. Well, and then we'll take questions. So now she's hitting even. All right, so that is just to show you that I didn't even go in her mouth yet, really. I didn't treat her jaw, and things were out of alignment, and we were able to correct her rotation of the first and second vertebra, and it balanced her mandibular occlusal plane. I'm not saying that's all she needs, but she definitely is now hitting even. Just as much as it's important to have an even pelvis when you walk, that you're not hitting harder on one side, same thing with the mandible. All right, so is there any questions that anybody wants to share or ask? Oh, and I see Isabel, thank you for saying that. I'm on the chat right now, but if anybody wants to chime in, please, you're welcome to ask anything.
Hi, doctor, this is Dr. Santucci. Awesome presentation. I feel like I want to watch it again. It was really good. Thank you so much. So I have a daughter who's like addicted to the tablet.
Yep.
And is, you know, I'm sure a lot. So we try to limit it as best we can, maybe to like an hour a day kind of thing, but
yep.
Still, I feel like it is, I don't know, maybe it's just me looking, I feel like it is kind of affecting her posture a little bit, like her upper body, and I can see that head forward situation. Are there any kind of braces that we could put on her or something? Because I feel like she almost needs it sometimes, just for 20-30 minutes. It's like her thing.
Yeah, you know what? How old is she?
She's 3.5.
Yeah, so, you know, my kids, we're in the age of technology, so
Yeah.
Teaching them how to use it, and even if you could get a little stand that she can stand and use it. It's this head down thing that you've got to avoid, that she thinks is normal. My kids, if they borrow my phone, they're 9 and 11, they have to have it up at their head. They can't look down, or I say, okay, give me back the phone. Kids at the age of 5, you should know that there's a program called GoPex that I do through an app that teaches the child, and there's a reward system. And if you want to go to ptrenaissance.com, there's a GoPex
Like
page.
Yeah.
PT and then Renaissance, physical therapy, PT Renaissance, RENAISSANCE. That has, like, if you want to learn about GoPex, go to the GoPex page, and it's transformed my kids' posture. You have to understand that. I mean, if kids don't learn to plant their feet, because kids, first of all, at age 3, the kids aren't fitting the chairs. Their feet are dangling, a lot of them. Unless they have a perfectly sized chair, you need a base of support. You got to teach them how to have lumbar lordosis. A lot of them, you know, I do work at my kids' school, and I go around and I teach posture and breathing to all the classes. That's what I volunteer to do. But they're all like this. All of them have, it stems from their back. So just know that you're asking a brace for a 3-year-old.
No, I don't.
She needs activity. She needs swimming. She needs,
Oh yeah,
you
yeah,
know,
we
that.
do that, but she's always like she's got to have like her hour at night, you know, kind of thing, and I just
So get her
trying
a
to get her out of
stand.
her stuff.
Get,
Well, we do have a stand that she put to make it more in the front of her face.
yes.
We do have that. Yeah.
And just know that if you start noticing her mouth being open while she's on it, like this mouth open thing, that's, you know that the palate starts to collapse when the tongue's down. That'll be next presentation, but just know that if she mouth breathes at night, there's a tape that I'm going to go over called myotape.com that has a hole around it that brings their lips together. And everybody needs to breathe with their nose all night to have a good night's sleep. So no, there's no brace, but posture needs to be learned early. So just know I work with kids at 5, and I could work with you or your wife on an app, and she doesn't even have to come in, and it works. So just know, but she's a little young for it. And I think a stand is the best thing right now for her. And just,
you work a lot with the ankles and everything like that, and the feet and things like that.
Yeah.
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 Okay.
Yeah. Listen, if any needs any, I'm a manual therapist. So head, toe to head, anything. It's to be a manual therapist, you're kind of like a chiropractor, but PTs tend to teach how to stabilize so that you don't keep needing to come back.
Okay.
You got to
We're
learn.
probably gonna have her come see you because she has some ankle things.
Yeah.
But,
Yeah. I mean, even if you wanted to come, we accept Blue Cross Blue Shield and Medicare. Okay. And all kids, I'm in network with kids. So if you want to bring her in and just have an opinion, please do.
Okay, cool. Thank you.
Any other questions?
We have to pick a date. We're going to try to switch some of the doctors are wanting to do Monday night. And
I'm